Good morning and welcome to our final opioid dependency treatment virtual health learning session for this year. My name is Carly Ruddy and I'm happy to co-lead this initiative with our medical lead, Dr. Rob Tanguay. Before we begin, I'd like to acknowledge that we are on Treaty 7 territory, so the ancestral and traditional territory of the Blackfoot Confederacy, and we respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I'd now like to introduce Dr. Rob Tanguay. He is an FRCPC psychiatrist who is fellowship trained in both addiction and pain medicine and is one of the few worldwide. He is the medical lead of the Alberta Opioid Dependency Treatment Virtual Training Program, the Canadian Society of Addiction Medicine Regional Director for Alberta and Northwest Territories, President-elect of the Pain Society of Alberta, and the incoming co-chair of the Alberta Pain Strategy for 2019. He is the founder of Canada's first publicly funded opioid deprescribing program for chronic pain. He is also a full member of the Hotchkiss Brain Institute and is involved in clinical research in opioids, pain, addictions, and cannabis. Dr. Tanguay has been invited as a plenary and keynote speaker for local, national, and international events, but most importantly, he's a father and a husband who's working hard to create work-life balance.
Yes, working hard, but I don't know if I'm succeeding necessarily. Thank you, Carly. I was told to try to not make funny faces while they read my bio, so I tried to not make funny faces. Thank you for doing that. Also wanted to recognize today is National Indigenous Day here in Canada, and if we can take a moment sometime during this day to remember some of the things that have occurred in our history, I think that would be important for us to do. These virtual health learning sessions are part of the Alberta ODT virtual training program. You can access the new training program at www.ahs.ca/PACES. That's www.ahs.ca/PACES. And you can take a look at some of the actual training program. It's available for free. And there are full credits available for it as well. So far, we've had over 1,300 practitioners enroll in the program, and we hope that the information we share both here and in the modules will have a positive impact on the attitudes and willingness of health providers to work with individuals experiencing opioid use disorder. We also hope that we see a significant reduction in the stigma of treatment. Often one of the things that occur is when you don't know how to treat something, you feel afraid of it, and that often leads to more of a stigmatizing approach to it. By simply understanding the basics of treating opioid use disorder, that stigma will dissipate. It just becomes no different than treating hypertension or treating any other illness that someone may show up with. Our sessions have been live streamed this year. And we'd like to thank Jeff Allen and crew, who are all here in front of me, as they ensure that this stuff runs so smoothly and does such a great job in doing so. They have been recorded and uploaded to the Concurrent Disorder YouTube playlist. This is at www.ahs.ca/CD series. You can see it there at the bottom of your screen. Give that a look. You can see all of the old sessions that we've done that are all recorded. We also have Section 1 accreditation with the Royal College of Physicians and Surgeons of Canada, and also meet certification criteria for the College of Family Physicians of Canada. If you would like to request a certificate of participation for your credits, please email concurrent.disorders@ahs.ca. Excellent infographics, and Jeff is on top of it today. Good job, Jeff. We really value the interactive aspect of these sessions. We want to hear from you. So please email concurrent.disorders@ahs.ca or text 1-780-220-8878 with any questions. You can also tweet live at Addiction Day please take a look at your screen for any of those modalities to contact us, and we'd be happy to either read comments out or answer any of the questions that you may have. And we may be looking forward to some questions and comments today, as we're talking about something that maybe can be a bit controversial, but at the same time, what we believe is the right thing to be doing. So again, send in your questions, send in your comments. Looking forward to hearing from you today. This is what makes it so special. And same thing, everything we're doing here is raw and live. We don't know each other's presentations. I simply ask the speakers to come with something that we give them kind of an idea of what they'd like to speak about, and then really open it up to them to do so afterwards. And that may lead to some controversy even on the panel, which is exciting. It's raw, it's live, and that is the reality of addiction medicine at this time. What I'd like to do now is read some bios from our incredible speakers that we have here today, and I'll go through each of the speakers one at a time, and then from there we'll start off with the presentations. I'd like to introduce Dr. Alvis Yu, sitting next to me. Dr. Yu is a family physician who completed his fellowship in addiction medicine at the University of Calgary. He is currently a clinical lecturer with the University of Calgary and works as a physician in Calgary's opioid dependency program. The Clare's Home Mental Health and Addiction Concurrent Disorders Unit, the Addiction Network servicing both Rocky View General Hospital and Foothills Medical Center, and the Transitional Outpatient Pain Program for Spine. Dr. Yu is also the incoming co-chair of the Family Medicine Fellowship with the R3 Enhanced Skills, and an incredible physician that we make sure most of our learners get a chance to spend time with. It's my honor to introduce via Skype from Oshawa, Mr. Chris Cull. Chris is a filmmaker and founder of Inspire by Example, as well as a recovering opioid addict. In 2014, he bicycled across Canada from Victoria, BC to St. John's, Newfoundland, raising awareness about prescription drug abuse. In 2016, he bicycled across Canada a second time, because once is not enough, to raise awareness about the opioid crisis, and also to show others that are in the position that he once was, that recovery is possible. He has been on numerous advisory boards, including the Canadian Minister of Health, the National Advisory Council on Prescription Drugs, the 2017 Opioid Prescribing Guidelines for chronic non-cancer pain, and is on the board of directors for the Canadian Centre of Substance Use and Addiction, something that we are all excited to see. So welcoming Chris via Skype from Oshawa, Ontario. Thank you for joining us, Chris. Cristina Zaganelli is a primary care nurse practitioner with over a decade of experience working with complex, marginalized populations with multiple comorbidities and high rates of addiction and mental health concerns. She completed her Bachelor of Nursing degree and her Master of Nursing degree and Diploma in Nurse Practitioner Studies. Cristina currently works at the Injectable Opioid Agonist Clinic. She previously developed a novel nurse practitioner role addressing the health concerns of both adolescent and adult patients with concurrent disorders. She also works at the CUPS Health Center as a primary care provider for homeless and low-income individuals. What an incredible panel we have here today. The goal today is to talk about I've stabilized my patient on Suboxone or buprenorphine, naloxone, or methadone, or SROM, or iOAT, or whatever we've stabilized them on in opioid use disorder. What do we do next? There's not a lot of guidelines for this. There's not a lot of guidance for this. There's different recommendations. You'll see things from Twitter experts saying that opioid use disorders like diabetes and people need to be on medication for life. To individuals who are in recovery who completely disagree with such. At the end of the day, every time I see my patients for an initial consult, we start off by talking about the need for opioid agonist therapy, and then we talk about what the long-term benefits could be and looking at the possibility of recovery and abstinence in the future. We should do that every single time we meet a patient and not tell them, you'll be on this for life. Because as you'll hear from Chris, hopefully, we know that's not always true. So we're going to start off with my presentation and talking a bit about recovery and what is it and what is resilience and what is addiction and what is this whole concept that we're here about. Then we'll hear from Cristina talking about the injectable opioid agonist therapy program, which is quite a bit different from safe consumption. We'll hear from Dr. Yu, and Alvis is going to speak about how do we clinically do this? What do we do in real life? What is the idea that we're going to be doing? And then we're going to finish it with someone with lived experience. If we're ever going to learn how to treat addiction, we have to talk to people who have been there and who have recovered from it. And that's where we're going to have an incredible lecture with Chris Cull. So we're going to start out by talking a bit about recovery. Turn my clicker on. Of course, I have my usual disclosures. I used to own a conference company, and in doing so, I've had to work with the pharmaceutical industry to do sponsorships of conferences. I've also worked in consulting. They usually never invite me back because I'm the guy in the back corner saying this is nuts. But anyways, I've really worked a lot with different industry. And in many cases, there's benefit in that, and in other cases, there's definitely some issues. But in reality, most of my work is about taking people off of meds. Also, a disclosure of commercial support. This came from the $10.4 million grant, restricted grant for the basically opioid crisis that we're sitting in today. And we get in-kind support from Alberta Health Services, which you'll see their logo everywhere. I think what's most important and something that we forget about is that about 1 in 8 Canadians have a friend or family member that have been affected somehow with dependence to opioids in the last few years. That's basically all of us. If you haven't personally been affected, you know somebody who's been affected. Nearly 3.5 million Canadians, 10% of our population or greater, have been affected by problematic use of opioids. This is a massive problem. This problem spans from using opioids for treatment and prescription to the unsafe illicit supply that we see out in the streets today and anywhere in between. And we have to be really aware that we as the healthcare providers and practitioners have to be the ones leading the way along with those individuals who are in recovery and who have been there and working together to make a difference in our society. I often remind people when we ask the question, what is addiction? Addiction is a symptom of our society, as is mental health, poverty, homelessness. These symptoms of our society really talk about the fact that we have some work to do all the way down to the ground roots of who we are as a society. But if we look at addiction itself, there's different definitions. This is the CSAM definition, which is similar to the ASAM definition. It's long. It talks about kind of the individual, the impairment, the behavioral impairment. Personally, I like the 4 Cs. It makes a lot of sense. It's quite simply a loss of control, a compulsion to continue to use, cravings to use when you're not, and continued use despite consequences. This is a simple process to understand, and understanding that it's a chronic illness with relapsing and remitting periods of time, and we should look at it in that format. If we treated it that way, the same as many other chronic illness, we'd probably be in a lot better state with the treatment of addiction medicine in this country. Substance use and addiction, often I'm asked, is this just a behavior? Is it a choice? Often it becomes a choice at the beginning. We choose to use a substance. It's usually a voluntary behavior to use initially. Usually. There's times that it's not. But that's just the beginning. That's not addiction. That's just substance use. That concept of the voluntary piece can be for many different reasons. Maybe it's to feel better. Maybe it's just to feel good as a whole. Maybe it's to do better, to be more active and proactive and to be able to get things done. Maybe it's just the curiosity of the social network that one is hanging out with and the peer pressure that can be interlinked with that. There's a lot of excellent research on peer pressure in adolescence, and the fact that oxytocin levels are so fascinating in this area of neurodevelopment, that the peer group is extremely powerful, and that peer use can easily lead to further use. So maybe initially it starts off as a voluntary process. Maybe that voluntary process has some benefit to people. With repeated use, sometimes this starts to change. For some people who are susceptible, and we'll talk about some of that susceptibility, that repeated use leads to those 4 C's, leads to cravings, compulsion, and consequences, that continued use and inability to stop using. That's really what kind of occurs over time. These risk factors for addiction get quite tricky, and simply we can talk about the neurobiology, we can talk about dopamine. Really, what's easier to do than looking at a rat brain and trying to figure out how addiction works, it's usually a lot easier to try to put it into some simple basics. We need to start off with a genetic predisposition. Some people will take an opioid, they'll get sick, they'll get dizzy, they'll get no euphoric effect, and it'll have no benefit for them at all. Other people will take it and find it to be something that's quite miraculous. They feel good. They don't have to think. They don't have to deal with some of the things that are going on. That has to do with our genetics more than anything. Then on top of that, adverse childhood experiences, and we'll expand into that a little bit more. Kind of the development of who we are, our coping skills, and what skills we have. This often leads to our ability to regulate our emotions, mental illness. We add on top of that risky behaviors and risky use of substances, and this kind of pinnacles at addiction. We can be anywhere on that scale, but really addiction is complex. And that's what it is. It's a complex, relapsing, and remitting illness. It's a chronic illness. The bottom 3 are some of the things that I really like to focus on, mostly because a lot of these are fixed and a lot of these are variable and modifiable. When we look at these risk factors, we can look at 4 major risk factors that can occur in addiction. Risk factor number 1 is that genetic predisposition. We talked about it. Risk factor number 2, childhood, adverse childhood experiences. The ACEs have been around a long time. We're going to talk more about it. Trauma, a history of trauma. Maybe it didn't happen in childhood. Maybe it happened in teenage. Maybe it happened in adulthood. Continued mental illness. Often these medications do wonders. These drugs, these substances initially do wonders for mental illness. I was just reading a really fascinating article about cocaine as an instant reversal for depression. We know long term it's going to be fraught with absolute negative consequences in using it for that reason. But there's some people that swear up and down they couldn't have gotten through life without using it during those periods. And we see that a lot with a lot of substances. Low resilience, little skills, poor supports. These are one of the things that are one of the major impacts in addiction. You may have a genetic predisposition, you may have adverse childhood experiences, but if you have resilience, if you have skills, if you have supports, that may trump things off. And finally, access. If there is no cocaine anywhere, you're probably not going to use it and become addicted to it. If there is cocaine everywhere and you're struggling with the other risks, that's probably one of the ones that you may end up struggling with. So access has always been something, and there's some excellent researchers that have looked at access points and looked at controlled legalization as one of the best ways to control access. But the reality is the most difficult harms that we see in addiction in our society comes from alcohol, comes from tobacco. These are legal substances that are the most available substances, and hence society accepts them, and hence we see the most amount of addiction and the most amount of deaths from these substances. Unfortunately, or fortunately, or however you want to look at it, alcohol kills over a long period of time. opioids can kill in minutes, seconds. And that's one of the biggest differences and why we've had so much attention in this area. When we look at adverse childhood experiences, early adversity has negative consequences in all facets of life, from physical health to mental illness, to drug use, to addiction. It really impacts all aspects of our health. And when we start looking at, it's actually a really cool website out of England, the 70/30, and pretty fascinating when you look at it, but it's also fascinating to see how just having 4 adverse childhood experiences significantly increases your risk of substance use disorder or addiction. And really, these adverse childhood experiences are so important. And the reality is, and this has been quoted many a times, it's probably the most important epidemic currently happening in our Western civilizations. And unfortunately, it's a difficult process to do much about, but we can do something about it. When we start looking locally here in Calgary, CUPS is a health center that really works with the lower socioeconomic status. And you can see the amount of people in their program that have high ACE scores. And the vast amount of the people that they see in their programs struggling with addictions, they go hand in hand. And these adverse childhood experiences have a significant impact. One of the ways to look at addiction and understanding it better is to take the Brain Story certification. I can't say how impressed I am in this program, and I've stolen some concepts from them that we'll go through. When we start looking at the concept of ACE scores, the concept of skills, the concept of resilience, I really love the idea of looking at a fulcrum and a teeter-totter sort of approach. When we start looking at negative experiences, they're on one side, and then positive supports. This is support, this is love, this is skills. Often people can have negative experiences and be surrounded by these positive experiences, but if they're not, then we end up, when we have these kind of positive experiences, we end up with more resilience and more positive outcomes. Unfortunately, when we tip to the other side and we have more negative experiences than positive experiences, we end up with less resiliency and end up struggling. The good thing is that we can add the positive experiences. And by adding the positive experiences, and again, I'll ask you to go to the Brain Story to check more of this out. By adding it, this is what true treatment is about. It's about building skills. It's about being there and being a support for individuals who need that. And it's about being there for people and helping them through a process, to help them through a process to recovery. That is the job of the addiction practitioner. And that is hopefully what I'm trying to relay here, is that we can change less resilience to more resilience. And we can do that in the format of a treatment program that really focuses on individuals. And it doesn't matter if it's an outpatient program all the way to a residential inpatient program. What matters is that we're working with people, we're next to people, and we're helping them build resilience so that they can move forward. We have a public health approach to substance use. And that public health approach really, one of the focuses or one of the wings is harm reduction. Harm reduction is extremely important. These are policies, programs, and practices that are about improving the health and life of those who are using substances. But we must remember that harm reduction is in all facets of life. Using a life jacket is harm reduction. Wearing a helmet is harm reduction. Server intervention programs is harm reduction. Environmental controls on tobacco smoking is harm reduction. Impaired driving is harm reduction. It's also really important to remember that harm reduction is policeable. And if we look at things like the Portuguese, policies and the fact that, yes, they've decriminalized most drugs and substances, to a certain point, you still can't use in public. you still can't be intoxicated in public. You can still be arrested for drug use. It's not illegal to have a certain amount of drugs, but if you have too much, it definitely is illegal. The idea that harm reduction means anybody can use at any time and that it's a free-for-all is completely false and doesn't really fit into the concept of what harm reduction is. Harm reduction is making sure people stay alive, stay safe. It's not about freedoms. The ultimate harm reduction, and we've talked about this many a times, when we look at injection practices, is not injecting. Kind of makes sense. But it also means using sterile equipment. It means using your own equipment every time and keeping it clean. It means not going to the point of sharing, of lending, of selling, of borrowing equipment. We know that that's fraught with difficulties. And really, harm reduction fits in all aspects, not just injection practices. The problem is the public health approach includes 4 pillars, not just harm reduction, but also understanding policing and prevention and whatever happened to actually helping people get treatment. These are important aspects of the public health approach and something that maybe we've lost our way a little bit with. The big question is, can we actually assess resilience? Can we measure it? Well, what is resiliency in the first place? It's kind of that concept of being able to withstand loss, to prevent loss, and to recover from loss. Often people think resilience is like that boggle clown that every time you punch it, it goes down and comes back up. But it's not always that true. It's also the clown's ability to dodge the punch, to withstand it and not go down, but also when one falls down to get back up. Resilience is measured in communities, in cultures, in corporations, as well as in individuals. Recovery capital is a perfect example of a way to assess one's ability to recover. And it really focuses on what does someone have, what are the tools that they already have, more so or less so on the deficits and more so on the assets people already have, and then determining based on those assets what level of treatment that they need. I think this recovery capital may be the future of what we're looking at in assessing individuals for treatment. It really focuses on a social aspect, a connection aspect, and a personal aspect with regards to recovery capital. Stable recovery is best predicted on the basis of recovery of assets, not pathologies. What do you have to make you move forward, not what's holding you back? We can treat those pathologies, but we need to add the assets. Again, we need to tip the balance towards recovery and out of the harm. There's obviously little agreement on what recovery is. We know that it's intensely personal and that everybody's path is unique. You'll hear about one person's path today, but everyone goes through a different path. It's our jobs to help each one individually find their path. When we look at recovery, I often look at it as a part of treatment. When we look at treatment, treatment is a spectrum. Addiction medicine is a spectrum. It's a spectrum starting all the way from harm reduction to abstinence. It includes medications for harm reduction, safe needles, safe sites, with full wraparound services. It includes treatment of the underlying pathologies, whether it's mental health, whether it's the trauma that's been induced by living the life of addiction and substances, helping people through those processes, and hopefully one day helping them feel free from the grips of addiction. And recovery is that individual process, and it's individual for everyone. One person's recovery today may be not to die. The next person's recovery may be to get their life back, their job back, their children back. And everyone is different, and it's our job to help them through that spectrum. And that's really what makes our job so special and so amazing, is literally we're helping people get where they want to go. We're helping them create lives and goals that they want. We're helping them create a life worth living again. So most importantly, many people choose to keep quiet about their recovery. And so the general public often doesn't really understand recovery and what it really means. And this is why it was so important to have someone who's been through recovery speaking to you today. All treatment programs, whether harm reduction or abstinence, absolutely require psychosocial interventions and wraparound services. This is the concept of we need to help people through the spectrum, whether they're activating and using one of our safe consumption sites to make sure that they don't overdose and die. That same individual in that position should have full access to treatment, access to finding a place to live, access to getting an identification, access to getting primary care, primary health care, access to psychiatry and psychology, and access, if they decide, I want help, residential treatment, intense outpatient programs, access to all wraparound services. And we know, and I've spoken about this a million times, the idea of this psychosocial combined with agonist maintenance versus just agonist maintenance, and the conclusion that intense psychosocial treatments don't improve outcomes, yet it was so fraught with biases and problems in the paper, even noting that the control intervention in the studies included basically routinely offering counseling. We know that psychosocial treatment for mental illness inside of protocols for opioid addiction improve retention to treatment, improve outcomes. This has been shown, this specifically looked at methadone. This has also been shown in office-based opioid treatment, OBOT, or the use of buprenorphine naloxone in primary care clinics. Just by adding a CBT program made a significant difference in retention to treatment and abstinence rates. Finally, a more recent article out of England that was published in Lancet Psychiatry, it's fairly reputable, I would say, looked at individually based psychosocial treatments, not intense, forced, rigidly based programs, but rather identifying what the individual needs and helping them through that process. Is it one-on-one? Is it group skills-based? Is it group mindfulness-based? Is it group support-based and AA-based? It's determining what works best for the individual. And in doing so, they actually helped individuals who were not responding just to medication treatment significantly improve retention to treatment and abstinence rates. It's quite a remarkable study and worth taking a look at. But once again, we see that if we provide a personal-centered or a person-centered care, we can significantly improve treatment outcomes. And the reality is we are never going to be able to treat the opioid crisis or the addiction crisis with a prescription pad. There is so much more that we have to do. When we look at trauma, the one thing that all of my residents and fellows and medical students who come and work with me, they'll spend time in pain, they'll spend time in addiction, they'll see both aspects. We're constantly screening everyone. And the one thing that everybody says at the end of their rotation when I ask them, what's the unifying thing you see, whether it's pain, whether it's addiction, whether it's mental health? And the answer is always the same, it's trauma. The amount of PTSD that goes untreated, and platforms of trauma-informed care. Look, don't get me wrong, this is extremely important not to be triggering everyone who walks in your door, but that doesn't mean that we don't treat it. It's treatable. The evidence is there to treat it in addictions. Whether they're using or not using doesn't mean we should or should not allow treatment. Edna Foa's work in COPE, which is all about treating PTSD with prolonged exposure, comorbid with addictions, has shown great outcomes that we can do it. It won't make their substance use worse. It won't make their life worse. And overall, we see significant improvements in both the mental health and in their substance use. And this should be available at all treatment centers, regardless of what we're doing. If someone wants help with what's happened to them in the past, and we know that what happened to them in the past has changed their brain, that what happened to them in the past has had an effect on their neurodevelopment and has had effect on overall where they ended up. And if they ended up struggling with addiction, we should be allowing them the freedom to have treatment, the freedom to be able to ask for help. And right now, we really struggle with that. Even the use of AA or NA has significant outcomes at 5 years in improvement of retention to treatment and improvement of abstinence rates. This isn't a first-line treatment, it's an adjunct, but it talks about how important supports are. And when we look at a biopsychosocial spiritual model of addiction, often AA fits in really nicely with that social piece, rebuilding social networks. Often people who are struggling with addiction for long periods of time, their entire social network are other people who are also using substances. And it really can have an effect on one's ability to recover. And these kind of programs really can help through that process. Recently, Russell Brand was in Calgary doing a really nice charity event. And in that event, he talked about his own recovery and his own struggles. And he talks about still going to meetings, and yet was still able to have fun with it. The nice thing about these programs is when your treatment program ends, when you're leaving residential care, when you're leaving intense care, when you're leaving whatever treatment care that you're in, NA and AA never leave. They're always there. You can go at any time. There's no cost to them, and it's just people wanting to help. So I really encourage you to support your patients and your clients to look at these kind of concepts and processes as further supports to help people through their pathway of recovery. And I always like to finish it this way. If we can think about stigma for a second, it is stigma that has really prevented us from giving the treatment that people deserve. We would never do what we do with cancer, with heart disease, with diabetes. Individuals with these problems, with these diseases and illnesses, often have first-class treatment, and it doesn't matter how rich or poor you are. That is not the case when it comes to addiction. There's an excellent commercial that talks about private healthcare coming to Canada, and it's a political one, but regardless, somebody having to pay and emerge. That's exactly how we treat addiction. If you have money, you can get anything you want, and if you don't, you're often in a wait list. In some areas of our country, you can't get any treatment. That would never happen to cancer. That would never happen to heart disease. That is where stigma lies. It's with us as a healthcare profession. And it's time for us as a healthcare profession to stand up and give the voice to the people who don't have one. And I'd like to again quote Omar, imagine a world where it's easier to get help than it is to get high. And that's our hope. I really would like to encourage you, if you're interested in this and living in the Calgary area, to check out the Recovery Conference. This is going to be in Calgary on September 11th. It's also going out throughout the entire country. So if you live in other areas of Canada, check it out. Paul Sobey was the previous president of the Canadian Society of Addiction Medicine and is an excellent advocate in this area. And Ray Baker is one of the leaders internationally in recovery, and hopefully you're able to come and see it. You'll also hear about the Portuguese experience and really learn what's going on in Portugal versus some of the stories that are going around. It's quite a bit different. And also, I encourage anyone working in this field to take the Brain Story certification. It's also free. It's an incredibly good program, and it really talks about the concepts of resilience, of neurodevelopment, of really understanding what addiction is and how it affects the brain and the illness of addiction itself. And I highly suggest that if you have a chance to take it, we have a huge uptake in Alberta, and it's being used internationally all over the world. And it's an Alberta-grown program, so please take a look at it. You've got nothing to lose by learning from it. And again, if you're interested in pain, there's my little plug. Come on down to the 13th Annual Pain Society of Alberta Conference. This will be a pan-provincial Western Canadian pain conference, and likely the largest clinical pain conference in the country, as the focus is on what can the clinician get out of it and what can they go home and use tomorrow. So with that being said, we're going to move on to our next speaker, and then we'll have a break after that. And I'd like to pass it on to Cristina Zaganelli.
Thanks very much. All right, so I'm going to speak more specifically to tapering of injectable opioid agonist therapy, but we'll talk about some practical approaches and some relatable concepts that make sense beyond this really specialized program. And I think it will relate a lot to what Dr. Tanguay's just spoken about, so some familiar topics. Just have a couple of disclosures around some educational events I've attended with Gilead and Indivior, and some consulting fees to the BC Centre on Substance Use. And again, the disclosure of commercial support for this program, as was previously mentioned, but no conflicts of interest. And absolutely, I need to make some acknowledgements to the clients of the Calgary iOAT program. They helped me put this presentation together, and I just want to certainly acknowledge their contributions to our understanding of what it's like to be an iOAT client, and also how to taper their medications. And also thanks to Dr. Ron Lim and Stacey Whitman from the iOAT programs for their input as well. Quickly, our objectives with my presentation is to review iOAT again quickly. I know some of you will have heard a bit about it from a previous webinar. And we'll talk about approaches to de-intensification of iOAT medication, the concept of rapid conversions, because I think that's what might have the greatest relevance to community clinicians. And I'll give you some examples of how we've approached this with some actual case studies. So iOAT is a clinic in Calgary. There's now one in Edmonton as well. We're open for 12 hours a day, 7 days a week, every single day of the year. We provide prescribed injectable hydromorphone for up to 3 injected doses per day. Clients attend 3 times per day and inject themselves intravenously with medication under the supervision of a registered nurse. We have a huge multidisciplinary team from RNs, nurse practitioners, physicians, social workers, addiction counselors, peer support workers, pharmacists, admin support, and we actually have a really strong relationship with our security team in the program that helps us provide this wraparound care for this population. So our clients are monitored before and after they inject with the medication around their medical stability, but that time is also spent engaging with them around the wraparound care. So what are their housing needs, their income support concerns, their safety concerns in the community? What other health concerns do they have? We're able to provide primary care services on site and even specialized care to the point of psychiatry consults, hepatitis C treatment, and other specialized services. They're changing all the time as we really get to know the needs of our clients. Our clients also receive a long-acting oral opioid. That would be slow-release oral morphine or methadone. They're given that with their last injection of hydromorphone in the day, and that's to provide them coverage and avoiding withdrawal symptoms overnight, as our clinic is not open from 7 p.m. till 7 in the morning. So they receive this medication just, again, to build stability in their life. I like to think of the iOAT program as like the intensive care unit of addiction medicine. When you think of the intensity of what we're asking clients to participate in, they attend 3 times a day. It really is an all-consuming experience. And we're providing a very intense and potent medication to address their opioid use disorder. When we see patients, when we meet them at intake in the program, they're often drowning in a sea of risk and harms, chaos and trauma. They are absolutely in survival mode. Essentially, all their waking hours are spent trying not to die. But opioid use disorder of this severity is a 24-hour-a-day experience where they're spending hours in acquiring substances, using, recovering, hiding, keeping themselves safe. This is why they need the intensity of a program like iOAT. So their hour-to-hour focus on survival is what brings them in the door. And then once we're able to get them on a medication that takes away some of that chaos and that hour-to-hour risk of death, then we're able to look at the other stuff going on. Truly, their bodies tell the story, and we see that when they physically walk into our program. They're hunched over, their hoods are up on their hoodies, their sunglasses are on. We cannot see them. When we do look at them, their skin, their hands show an evidence of huge history of trauma, physical trauma, as you can see from this gentleman's arms. he's been injecting for years, and his body shows the scars of that. But we see many other scars as well. They've all experienced physical trauma. They've all experienced psychological trauma, whether in their childhood, their adolescence. For the vast majority, that's the case. But undoubtedly, everyone in their adult lives have been traumatized. They've all overdosed, and they all inject. So this is the tip of the iceberg in terms of severe opioid use disorder. To provide some perspective on the tolerance that they come in the door with, this is really important to understand if we're going to talk about tapering their medication. Their tolerance for opioids is absolutely incredible. If you think of an average person, an opioid naive person, if they were to walk into the acute care or emergency department needing acute pain management, we would be giving 1 to 2 milligrams of hydromorphone, max, and then seeing what happened. Clients at iOAT are prescribed doses that are typically between 75 to 150 milligrams 3 times per day, up to a maximum of 250 milligrams per dose, up to 3 times per day, plus or oral opioid. So the morphine equivalents often exceed 1,000, and some up to 5,000 morphine equivalents per day. So that's a lot of opioids that we have to deal with. So this leads to the natural question, and this would be the question I get not only from clients, but actually more so from health practitioners, is do people ever get off this stuff because of how high their doses are and how high their tolerance is? So we know they come with this incredible tolerance. We have to stabilize their illicit use so that they're able to engage in other aspects of treatment. So yes, they're able to get off this stuff, and we can help them, but it has to do with that wraparound care and looking at the broader aspects of their substance use and what's underlying it. So first is to stabilize, stop using street opioids, decrease the chaos, and then that in turn builds space to look at the other stuff going on in their life so that we can actually address the underlying issues related to their substance use. The timelines around when and how someone changes the dose of their medication or gets off this stuff is really up to the individual client, and it's very responsive to their needs. They may not know when they come in the door what their ultimate goal is. That will change, and we need to keep reevaluating the longer they're in the program. And we certainly do need to ask on an ongoing basis what they want to achieve in the program and if we're helping them. And if not, what do we need to do differently? So a very client-centered approach is the name of the game here. So you can see that we're providing a safe supply to begin with. Really, that's what gets them in the doors, a safe supply of opioids compared to the toxic or contaminated supply of street drugs in Canada right now. We're providing supervised injections so that if they do have an adverse event or an overdose, we can respond. And we're really trying to drive their street use down and into a supervised and controlled setting. That gets them in the door. Then we do more. It's deeper connections. It's retaining them in the program. It's feeding them food. It's really starting that recovery conversation and having them define what that looks like for them. Really looking at relapse prevention skills and building skills to live a different life. And in doing that, we really need to improve their health and help them improve their own physical and mental well-being. So primary health care embedded in the program is a very important aspect of what we do at iOAT. Screening and intervening around mental health concerns, infectious disease, and other primary care, chronic disease management is also integral. And following up. So we can start things, we can do screening, but if we don't follow up and review test results and talk about treatment options, and then maybe test again in the future if the risk for, say, hepatitis C still remains, that we continue to meet and address these health concerns. I think another thing that we do really well at iOAT is we look for you if you're missing. So we want to maintain these connections, and we don't just put it on the client to come to us. If we miss seeing you in the program, if there is an absence that's unusual, we'll look for you. And I think that is part of the wraparound care. People still have, obviously, the ability and the right to leave the program, and they certainly do, and that is absolutely okay. But if people go missing, we will try to connect to understand why and to provide some additional support. So really with this population, if the chaos and the fear of poisoning and death is ever present, it's hard to work on recovery. If we can take that fear and that risk away, then the space opens up to do this other work. So once we've been able to, say, work on housing and work on other health concerns, sometimes it comes up, and it has already, even in the short existence of the iOAT program, that clients want to reduce their dose or reduce the intensity of their treatment. So when we look at de-intensification of iOAT, ideally it's client-driven. When they're stable on their iOAT medication and they're wanting a less intense approach. Sometimes it's simply that they want to travel, perhaps to a family event or for Christmas, a weekend away, and that sometimes can spur that on for short bouts of converting their medication to oral doses. And then sometimes we have the opportunity to do a slow taper over time. Sometimes it's system-driven. Our clients engage with the healthcare system all over the place in other parts of the system as well. So they end up incarcerated, hospitalized, or they may be seeking other kinds of treatment in residential settings that won't allow the injectable hydromorphone to be part of the plan. So we sometimes have to do some tapering rapidly to address some of these other pressures. Sometimes, and rarely is it ever program or provider driven to de-intensify or to taper iOAT. And so we really do avoid it, but sometimes it is a temporary consequence due to violence or a significant threat or behavior in the clinic that poses a safety risk or repeated diversion of the medication. So the key points around de-intensification are to use the guidelines that we have, and there aren't many, but to use them, but also know that you are venturing into uncharted territory. So we are learning as we go. Clinical judgment is huge when we're changing medication doses, especially with this incredibly high level of hydromorphone use. Monitoring and pacing and really following up with the team so that the wraparound care continues for this individual, even if the milligrams of hydromorphone goes down. We're not tapering support, we're tapering the dose of hydromorphone. So client-driven tapering is our goal, that's ideal, and we really just need to get on the same page as the client. Sometimes that's an ongoing conversation over several visits, what their goals are, their time frame, and what the approach is going to be to tapering. Sometimes we hear that they'd like to just say, forget it, and be done with all their injections and switch to oral tomorrow. And if we can, we work on pacing that and tapering it down slowly. We want to assess their insight and their understanding of their relapse risk and what their recovery capital is so that we can capitalize on their skills and work on enhancing the supports that they find meaningful so that they can have a successful taper. So that means looking at their social determinants of health, and that's broadly beyond our medications and goes to housing, income support, food access, how they pay for their medications even, who they hang out with, who they spend time with, how are they accessing primary care and other health services. So developing a relapse prevention plan is also important too, so that they maybe have a written document that they can refer to and other resources like NA meetings, smart recovery meetings, or other treatment programs that they might be heading towards. And we have to be open for the readjustment of a taper because this is new territory. This level of hydromorphone, this dose of medication is unprecedented. So how to taper that and how that will feel for the individual needs to be part of a constant evaluation and readjustment. And slow is ideal. And constantly checking in with the client to see how they feel and giving them permission to pause or delay a taper if it's not feeling well for them at the time. And not seeing that as a taper failure or a setback, but just part of the process. So we can get really hung up on the milligrams and morphine equivalents when it comes to this medication and this treatment at iOAT because it is pretty astounding, but it's way more than that. So it has to do with all these other aspects of an individual's health and well-being. And so this model fits, I think, well with what Dr. Tanguay was speaking of in terms of the wraparound care. A lot of our clients are very homeless, as in they live outside, even in the winter time. So their access to shelter and food and proper clothing is a huge issue that needs to be addressed, because that, causes, incredible risk should they relapse. And it also is very hard to focus on higher level work, like treating their trauma or even their hepatitis C, if they have nowhere to sleep and no food to eat. So we do a lot of this work at iOAT. We provide food, we support in accessing housing, we provide a lot of on-site care for mental and physical health issues. We even walk people to the bank and open bank accounts. We walk them to their probation officer appointments so that they don't breach the terms of their release and they can stay out in the community. We help them get ID. They don't have identification, and there are many steps to that process. So we work on all aspects at iOAT, and that's where we're seeing the greatest successes, is when we're able to tick off these boxes and get people more stable in all aspects of their life. But when we are looking at changing or tapering their iOAT medications, the principles are pretty straightforward. We're going to decrease their hydromorphone. We're going to decrease the number of sessions that they attend at iOAT where they're injecting hydromorphone, and we're reducing the number of injections in total that they experience in a day. We're going to increase the dose of oral opioid agonist therapy at the same time. We're going to increase their relapse prevention skills, and we're going to enhance their psychosocial support. So those are all happening simultaneously. So we are a very intensive program. We start by decreasing the dose of medicine, but we don't want to taper off the support, because that's what's keeping people connected and definitely enhancing their wellness. This wraparound care is cornerstone. We also bridge to other services, because we aren't going to be all things to all iOAT clients forever, and we want to help them connect with the broader system. But they've often had terribly marginalizing experiences over and over and over again, whether it's through the emergency department, through inpatient units, through other treatment centers, and we need to help bridge them back to those services and have more corrective experiences. Occasionally, we do have to briefly taper someone from their iOAT medications, but we really try to avoid it. We use a team-based approach to determine when we have to do that. Usually it's around a behavioral or safety concern, and it's always temporary. We know that it can result in the deterioration of somebody's physical and mental health, and so it's not a decision that we take lightly. If we do taper somebody for a behavioral concern or safety reason, we always provide oral medications as an alternative, and we try to enhance the other supports in the meantime. The point being, we just don't cut people off this program. It's terribly unsafe. Excuse me. So if iOAT provides care at the tip of the iceberg, why is this important to anyone in the community or in acute care? The reality is all of these iOAT clients engage with the healthcare system and other parts of society, whether it's in corrections, through police, through the hospital, and they need care when they're in these other services. So we do also plan and hope that our clients will graduate to other programs, and so to understand what they've been through and what the process has been is important as well. So you may see iOAT clients in your service. You may also see clients who you think could benefit from iOAT treatment, and to keep that in your mind as a treatment possibility for people with very severe opioid use disorder. So ideally we go slow, but sometimes we do have to go fast. And these rapid conversions are in the guidelines to help guide us when there are urgent needs to taper somebody off of their iOAT and move them to oral medications. And the situations that we see most often are incarceration and travel. Hospitalization, less so, because we are working with our hospitals in Calgary to have them carry on with the intravenous hydromorphone dosing while someone's admitted for other health concerns. So we're having some success there, and we're certainly working with the arrest processing unit in the Calgary Remand Center to carry on iOAT medications while they're in those facilities. If we do need to do a rapid conversion, we have a handy table here. This is just an excerpt from the guidelines that are from the BC Centre on Substance Use. And you're actually able to do a quick calculation of their total hydromorphone doses throughout the day and convert them to slow-release oral morphine or methadone. We max out at 1,200 milligrams of slow-release oral morphine in a day, or 100 milligrams of methadone for a rapid conversion. And we always have to take that cross-tolerance issue into account and reduce those conversion doses by 25%. But we have a very useful tool that we use all the time to help convert these doses that our clients are on so that they're able to succeed and avoid withdrawal when they're in other services. We do have clients who have family and who want to have Christmas dinner with their family in Red Deer or other towns outside of a center that has an IO facility. So we want to support people engaging in healthy relationships as well. So if it means a weekend away where they convert, we use this tool to convert their medications to oral doses so that they can go to a family event. By all means, this is an important part of building support beyond our program. So I'm going to quickly review this one example of how we do a rapid conversion. This is a 38-year-old male, an IO client, who is stable on 80 milligrams 3 times a day of injectable hydromorphone and 50 milligrams of slow-release oral morphine. He engaged in some threatening behavior towards staff that was, when the team discussed it, it was deemed that he should have a 24-hour suspension, sort of a cooling off period. In doing so, we converted his injectable doses to oral and advised the client that he had this 24-hour period away from our program, but that he could come back and get his oral medication before taking that break, which he did. And then he came back the next day and was able to immediately resume his IO dosing. So we know the recovery capital, the coping skills of the individuals in the IO program are limited. And so we know that there will be times of anger and outbursts and behavioral issues. We expect it, and we are looking at the best way to support these individuals in building coping strategies that are healthier, but also acknowledging that when there is an issue that makes other people, other clients feel unsafe, that we can, in still maintaining the safety of the individual, also create a safe environment for staff and other clients. Another example is a client-directed taper. And this is a 40-year-old female from iOAT who is stable on 100 milligrams TID of IV hydromorphone and 250 milligrams of slow-release oral morphine. And she wished to attend a residential treatment program. This was her goal when she stepped in the door and became a greater focus as she was more stable in our program. Because we had an intake date determined by the program, we were able to taper her off her hydromorphone, looking at the calendar and focusing on this intake date. It was a little faster than we probably would have done so if it was just up to us, because the intake date was dictating some of the timing. But this is how we did it. We slowly decreased her dose of hydromorphone by about 5 milligrams a session, spacing those dose reductions by several days, checking in with her frequently around withdrawal and cravings and any illicit use. And at the same time, we were concurrently increasing her oral medication. Eventually, the third session was eliminated, and she was carried on with 2 sessions of IV hydromorph, eventually down to 1, and then stopped completely her injecting sessions and increased on an ongoing basis her oral medication. We also used other medications to manage her withdrawal symptoms and to minimize some of the physical effects. And there was lots of support and daily, multiple times a day, checking in with the client and working on the pace and looking at other supports that would help her feel successful. So I asked her, how did it go for you? What was, as one of the first people in our program to experience this, what was this like? And her general review was that it went well, that it was what she wanted, it was on her terms, and it was a positive experience. It wasn't easy, but it was positive. The hardest thing for her was when she had to drop a session, because it meant not coming into the program and having that contact, and that was a real change in her routine. So that was the hardest for her. But the most helpful thing was knowing that she could increase or slow down the pace of her taper, because this was directed by her in concert with the team at iOAT. So a really good experience that we can build on for future tapering plans for individuals at iOAT. So she still remains connected with our program for that very reason, that we provide more than just her hydromorphone. It's that wraparound care, the psychiatric support, the social support as well. It's more than just milligrams of hydromorphone. For this individual, she got housing, she met with a psychiatrist, she had her medications adjusted for her incredibly potent PTSD symptoms. She was eating and sleeping. So basic functioning was definitely a part of this success story. I can't say it enough. What we've learned at iOAT is the wraparound care. And I think this can be applied broadly to other addiction treatment programs. It's the care beyond the prescription pad that makes the difference for our clients, and they're telling us that directly, which I think really sends a message home for me. This is a quote from one of our longer-term clients, and he says, this is a direct quote, that you guys are my brain. I can't remember anything on my own, and you helped me get to all of these appointments. This place saved my life. Without this clinic, I'd be doing crime and back in jail. This is the longest I've been out of jail, and this place has saved my life. This is an individual who has had a very long history of incarceration and hospitalizations for physical health concerns, but was never able to see them through those hospitalizations because he would leave because he was in incredible opioid withdrawal and very uncomfortable. Now he's been hospitalized once during our time at iOAT and for a physical health concern, which he stayed the entire duration of his admission and has actually seen the near resolution of his chronic health concern because of that stability and the maintenance of his hydromorphone treatment while he was in hospital. So this is what we hear from clients. They say thanks. They do thank us for the medication. I think they think it's useful and it's helpful, but they firstly thank us for the community and the support. So I think that's a very notable thing. They're thanking us for the community that's developed at iOAT. They notice the improvement in their basic functioning. Sleeping and eating are basic functions that we could take for granted, but that's what people notice first, that they're not worried about getting arrested because they're outside with drugs. So they're actually able to go to their shelter or to their home and sleep. They've eaten during the day so they can rest at night, and there's a sense of safety. So we're seeing this individually affecting people in a very positive way, but I think we need to be really clear that society benefits when we look after everyone. And when we're looking after these individuals in particular, we're all benefiting from reduced crime, reduced use of the healthcare system, and building trust and relationships with people who are incredibly marginalized, because they will become assets to our program and also to society as a whole. So tapering iOAT is a pretty specialized topic, but I think it bleeds into this broader topic of recovery and wellness and what it takes to look after people in our society. And thanks for your time hearing about it.
That was excellent. Thank you, Cristina. And I totally agree. This is about basically the highest level of harm reduction and treatment incorporated together, where we're not only providing a safe supply of opioids, we're also providing structure, support, and quite simply help. And pretty amazing program, maybe what all supervised consumption programs could look like in the future. But that might be a bit controversial. Who knows? Yeah. We're going to take a 10-minute bio break, and then we're going to have Chris Cull come up next, as he's been waiting patiently from Oshawa, and we'll have him joining us live from Skype. It'll be exactly 10 minutes. We have a timer in here. It will not be 5 minutes. I know we've taken some flack. So we'll be back in exactly 10 minutes, and we'll have Chris Cull at that time talk about his experience. Thank you so much for joining us. And again, remember, if you have questions, and we have a few that have already come in, please email concurrent.disorders@ahs.ca. You can text at 1-780-220-8878, or you can live tweet us at Addiction Day. We will take your questions any way we can. If you have any comments, we'd love to hear from you. Please keep those questions coming, and we'll be having a panel at the end. And maybe at the end of Chris's talk, because he's got to run, we'll take any quick questions that anybody may have for Chris, if he's okay with that. So we'll see you in exactly 10 minutes. And we're back. Thank you so much for coming back. Again, we're really enjoying some of the questions that we're getting. I'm feverishly texting my colleagues in Edmonton for some of the questions because, you know, it has to do with funding and money. Regardless, we'll have answers for you if you hang in there. Again, if you have questions, please email concurrent.disorders@ahs.ca, or you can text us at 780-220-8878, or you can tweet us at Addiction Day. If you have comments, concerns, anything at all, throw it out there. We'd be happy to try to deal with it. Our next speaker, as mentioned, is Mr. Chris Cull, one of the board members for the CCSA, and he's going to be speaking to you today about his experience. He's coming live from Oshawa on Skype, and we'll do it a little bit differently because Chris has got to take off. We'll have a bit of a Q&A for any questions that anybody may have for Chris. So if you have them, make sure you're emailing him to concurrentdisorder@ahs.ca, texting him to 780-220-8878, or live tweeting to us. And it's my honor to hand this over to Chris.
Great. Thank you so much. Thank you guys for inviting me to take part. Just going to get right into it here. Just get everything open. I'm hoping everything's fine on your guys' side with the screen and everything. But again, my name's Chris Cull. I'm 34 years old. I'm a recovering opioid user and advocate. But today, first and foremost, I have no conflicts of interest. That said, I'm just going to be telling my story today, nothing more, nothing less, and just the journey from my beginning of opioid use to the 7-8 years after it, and what's brought me here today. So my story begins with my father. He was a paramedic for 27 years here in Durham region in Ontario. He was my hero, and when I was a teenager, roughly near the end of high school, he was diagnosed with Huntington's disease, and shortly after that, his onset kicked in, and it took everything from him. He ended up, as it progressed, he ended up losing his job that he loved. He ended up losing his license. He couldn't really go anywhere, and he started drinking very heavily to kind of deal with that pain. And when I was roughly around 20 years old, he started trying to take his own life on a fairly consistent basis, where I was coming home from school, and for instance, in a time where he was trying to hang himself in the garage. And over time, that stress really built up. And then on May 4th, 2007, it was a Sunday, and I was on my way out the door for brunch with my girlfriend at the time and her family, and he told me he was going to go out for the night because he hadn't left the house in weeks. And I said, yeah, go for it. My mind wasn't really thinking down that line at that particular moment, but he gave me a hug and told me he loved me and said goodbye. And that was the last time I saw him. I came home. He didn't come home that night. I went to school, and I came home when he still wasn't home. When I got back from school, that's when I really started getting alarmed, and I ended up backtracking all his steps to found out he checked into a hotel there in my hometown of Bowmanville. And so I went down there and met the paramedics, who happened to be friends of his that I had known for years. And we walked in that room together and found him. He took his own life in that hotel room. And that broke me as a person. That I didn't know how to handle that. I just snapped like a twig. But that's kind of where after that, I just didn't know how to handle it. And that's where my opioid use began. But my drug use certainly didn't start with the opioids. It wasn't that I really did a lot of drugs prior to that. But I tried smoking cannabis shortly after high school. I didn't smoke or use stirring. I tried cocaine for my first time at age 19, but I didn't really get deep into it or anything like that. But after my father passed away, I just didn't know how to handle it, and I started using Percocet to kind of numb out that pain. So I just didn't want to feel the way I was feeling anymore. I was crying arbitrarily in front of everybody I knew, and it was pushing people away from me. And kind of using the Percocet was kind of helping me through. So I started out using a couple a day. That went up to 5, then to 10, then up to 20, and then it ended up actually capping off closer to 25 to 30 Percocets a day. To which case, then I was introduced to OxyContin. Or oxycodone, and that just sent me to a whole nother level of opioid use disorder, where that escalated using up to 580 milligram Oxycontins a day for 2 years, and I lost everything that meant anything to me to that. The consequences of it all was I spent over six figures on drugs easily. I lost a girlfriend that I was with at the time that I loved dearly, and I lost my sense of ethics and morals, and I dropped weight like crazy. Like, people were calling me a junkie, and my friends, my family, for the most part, didn't want anything to do with me anymore. And then, to which case, my only friends were the people I used with, and obviously became physically dependent, where I couldn't go without it without going into deep withdrawal. And this picture right here, that's me on my right. That's when I was about 139 pounds. And just to give you context, I typically walk around at about 185, 190 now. So that was when, yeah. So after I actually, because my father, he left me everything, and that's kind of how I funded that usage. And once it actually was at the point where I lost the house that he had left me. Which that was devastating, and it was my own fault. And so I knew I had to change. I tried going cold turkey twice. My mom, she's a charge nurse at a hospital in downtown Phoenix, Arizona, and her husband's a physician assistant. So I went down there to try to go cold turkey and get off, and they ended up I actually ended up leaving there and coming home early, because I was just too deep in it, and it wasn't a good scene down there. They didn't even really know I was coming down there to do that. But I ended up coming home fairly early, and then just fell right back into pills. And after that, I needed to do something. And so I began the methadone program to stabilize. This was before Suboxone was even out. So methadone was kind of the be all and the end all as far as the harm reduction was concerned. So I went on that program, and I had to stop being around everybody I used pills with, because it was just detrimental to where I wanted to be. And at that, I started working as a cashier at Walmart to create an income, to start kind of trying to build my life and create some stability. Now, the journey through methadone was a rough ride. I was on it for 5 years approximately, but once I actually started on the program, I started using cocaine not every day, but frequently enough for the first 2 years, and that was very detrimental to everything. I didn't make any progress in that first 2 years, but something great kind of happened out of that. Around that time was that I got switched to a different doctor versus the one I initially started off with, which was actually changed my life, but I'll get into that in a moment. So after I actually stopped using all the drugs and I started getting my carries and was clean samples, I had spent so much money that I went 2 years without gas in my home, because after my father's house I sold, I got a smaller house, and thankfully was able to have a shelter to stay throughout that time frame. But I couldn't afford to keep the utilities on, so I went 2 years without gas, where I was curtaining off my living room and heating water, like in the wintertime, and heating water on my stove to clean myself, and was going up to 4 days without eating on well over a dozen separate occasions. And that's kind of where a lot of that weight loss came from. When I bottomed out at about 135, 139-ish. And so I started stealing my food to eat, which wasn't a pleasant experience. But when you're kind of in that position, you understand how morally flexible you can be to just to survive for that matter. But so one day I was working my job at Walmart there, and a guy came through with it was just like any other shift, and a guy came through with his groceries and everything like that, and so I was scanning all his items through, and there's these 3 apples at the very end, and I put the apples on the scale and I punched in the numbers, and he told me it was the wrong price, and I pulled out the flyer just to show him it was the right price. He grabbed the stuff and stormed off, and I didn't really think much of it at the moment. And when he, unbeknownst to me, he went over to the produce department, and you know those hard plastic signs that dangle on the produce bins that you slip the numbers on that have the price there? He grabbed that sign and came back to my line, and he ended up frisbeeing that sign into my nose, which cut my nose open to save 50 cents on 3 apples. I told the guy I had low regards for him and quit my job that day. I just wasn't willing to take that anymore. But I mean, that was actually probably the greatest thing that happened to me. That was when people ask me what the defining moment was that kind of helped turn that around. I definitely attribute that to probably 1 of 3 times. So I went home. I started looking for a new job, and I remember just sitting there thinking for hours, just in silence, that I was tired. I was tired of surviving, just keeping my head above water. I was tired of stealing my food, not having a shower, I was tired of working a job where I was staring at the clock all day, just wishing I was doing anything else but that. So I kind of put a pause on, for the moment, for looking for a new job, and kind of really got down to what it was I wanted to figure, or what I wanted to do with myself. So I ended up creating my own system to figure out what it was I wanted to do with my life, where I wrote down 4 boxes with my passions, interests, hobbies, and stuff I knew I hated, and just to be able to cancel things out, and then broke it down into goals and then stuff that I wanted to do. Now, during my ride in 2014, I produced and directed a documentary about the opioid crisis, but at that particular time, it's just like, well, how do I get this going? So I spitballing my idea with my friend Nicole one day, and she introduced me to who ended up being my co-producer, Shia, and we met ironically at that side of that Walmart, and just decided that we wanted to work together. So that was all the motivation I needed. So I started taking the bus to the Bowmanville, Ontario library to use their internet and computer, because I didn't have internet, much less a computer. And then I didn't have cable, so my only entertainment was reading at that particular time. And I took out every single book that I could possibly think of related to what I was about to do, in order to mitigate any of the risks that were going to come my way with this huge endeavor. The house that I had left, the house that I had, I ended up selling it to help fund it. The reason why I could have sold it and kind of gotten out of my position earlier, but I was thinking about, like, I'm not losing. This is my last shot, and I'm not going to lose it just to fall back down the same hole. So I preferred to ride out that rough ride and make sure I did it when I was ready. So I began training, and kind of over this time frame, over about a year and a half, I tapered down off of opioids and then completed the methadone program. So tapering was an arduous process, to say the least. I started out with methadone on 30 milligrams, and then it kept going up and up and up. Admittedly, I abused the program. I certainly didn't need to be up that high, and it kind of made the process a little longer. But it's kind of what I had to go through. I don't really regret it, because it gave me a lot of great experience that I could use to help people. So over that year and a half, I tapered down to 0.5 milligram daily dose, and I stayed at that dose for about 3 weeks to a month, just to ensure that when I made the leap off, I wasn't going to go into any kind of withdrawal. But I mean, you have to listen to your body with it. It's you can't really set a timeline as to when you want to get off. I mean, I would drop 120, I started out dropping 5 milligrams biweekly until I hit about 60, 70 milligrams daily dose, where I would drop 5, but it like I was really starting to feel it. And part of it all was like, so what I would end up doing is going back up 2 milligrams, say, and then feeling that out and seeing how it reacts. But that mental win, like that drop in the 5 and then having to go back up 2, I'm still down 3. So it was always a mental win, and it was always about having those small little gains that they're very incremental, but they were the key to the process. But like going back to my first methadone doctor, all I ever remember that guy talking about is his cottage he was fixing up. I didn't like him, much less respect him for what just kind of his approach to it. But I didn't understand what that contrast was until I had my second doctor, and she changed my life. She's a hero of mine. I have the utmost respect for her, and still keep in touch with her to this day. But yeah, like my biggest advice to any physician out there, for harm reduction or otherwise, is when you believe in your patient, they believe in you. And once you build that trust, I mean, having that one person that you can go to, that you go to when your whole family thinks you're a write-off, and this one person that you really barely know believes in you because no one else does. And you're in that position because your patient feels like you're the only person that can help them. Once you create that trust with one another, and then you can take them wherever you want, and you work together. But you work together to navigate that process. But you can't navigate that process if you don't trust each other. And it starts by just getting down to the bottom of things and asking questions and making them feel welcome to be there, and that you will do your best and everything in your power to help them. But and at that, to Rob's point earlier, is that, yeah, everybody's path is different. There is no one-size-fits-all solution. Everybody has their toolbox of tools they use to recover, and everybody's tools are different in their toolbox. And I think that's probably the most important thing. So when you're trying to develop that trust with your patient, understand that because something worked for one patient might not necessarily work for the other. But that whole baseline of trust is everything in terms of helping your patient taper or make the leap off, or whatever the case might be. But another massive part of it all was I knew I tried getting tapering probably about 4 or 5 times over that 5 years I was on methadone. And I found one of the biggest differences that in the time I succeeded versus the times I failed was I knew exactly what I wanted to do when I got off, and I had a plan to where I wanted to go and everything I wanted to do. So thus, I mean, getting off methadone is like it was my Mount Everest. I kept trying and trying and failing. And then once I was able to compartmentalize the goal and just turn it into a step into something bigger, it didn't seem so overwhelming anymore. And having that vision of where you want to go with your life, I mean, that dream of being off and doing whatever you want to do with your life, it's very motivating to find the path off. That said, what I came to is I wanted to use my experience of opioids. I'd seen so much over those years that I could write a book and not even come close to touching on them all. But I also understood I had a unique knowledge base that I could use to help people that you can't go to school for. And knowing that, I just wanted to utilize that skill and help people that are in position that were in like me. So I started to, the inspired by example, it was to do the film, to document stories from coast to coast about the opioid crisis, do the ride across Canada to show that you can, no matter how hard it is, you can get past everything. The addiction awareness and just living your life, just showing that no matter how deep or dark of a hole you're in, you can turn your life around and turn it into something beautiful. But the learning curve was fairly steep. I had no experience in film, journalism, public speaking, public relations. I hadn't rode a bike in 8 years, and I just got off methadone. Naturally, everybody I knew and then some thought I was going to fail. But at the end of the day, this was the first time I ever did something for me. And the whole resolve that being able to get off methadone gave me was, well, if I can do that, what can't I do? So I just tried to push those limits, and thankfully it all panned out. But so I've done the ride twice, but my first ride was Victoria, BC to St. John's, Newfoundland. It was May 15th to August 27th. It was just under 8,000 kilometers, and I was doing the documentary, documenting all the stories and including my own story along the way. But part of it all was going out and doing all the crazy stuff I wanted to do that I couldn't do when I couldn't travel because I was going to go into withdrawal. So hammered a bucket of golf balls off the mountains of BC, jumped out of an airplane over Montreal, whitewater rafted northern Ontario. We climbed an iceberg off of Newfoundland, but we got into a lot of trouble for that. But still a great time, but almost got arrested. But yeah, so the film. So this was the ride itself wasn't even what I was concerned about really when I was on the road. It was because I had no experience in how I was going to find these interviews. So it was just a lot of networking, and thankfully it all panned out. But yeah, so I started in Victoria where I interviewed a nurse that was taking pills from her hospital, got caught. She was in recovery and doing great now, or at the time I was interviewing her, and shared her story. Vancouver's downtown east side. That was crazy. But a mother in Calgary, her name is Sharon. She lost her 19-year-old son, Christian, 9 months prior to my interviewing her in Calgary. And that was probably one of the more eye-opening interviews I'd ever had. But so that to addictions counselors, harm reduction doctors, to advocacy groups, to the head of the OxyContin task force in Newfoundland at the time, to the lawyers who were doing the class action lawsuit against Purdue Pharma for their misbranding of OxyContin. So yeah, I don't know. It's a short synopsis of what I kind of the adventure of it all. But where I'm at now is, yeah, I was appointed by the Health Minister of Canada last year to the Board of Directors for the Canadian Centre on Substance Use and Addiction. Out of Toronto here, I work on for the Central East LHIN's Opioid Strategy Action Group. I also work for the Municipality of Durham here on their Durham Region Opioid Task Force. As mentioned in the bio, they're the opioid prescribing guidelines for chronic non-cancer pain. My goal is what I'm trying to put together right now is one last third ride across Canada with a TV show where, so as the premise of my film was going out and documenting all these stories from coast to coast, I want to broaden it out more to overall mental health and addiction, hear stories of people who went to the complete brink of destruction and then came back, and then take them out to do something they've always wanted to do. So it's kind of like a Make-A-Wish Foundation for mental health and addictions, for lack of a better wording. That, and I do motivational speaking around North America, which has been, I really enjoy that, and it's probably one of my favorite things to do. But that said, just to kind of cap it off, I learned a lot. I couldn't write enough lessons down. Well, I'm actually trying to write a book, in the middle of writing a book right now, so I'm going to try to nail out all those lessons in there. But yeah, personal accountability is my number one thing. It was something that my doctor my second methadone doctor really taught me a lot about. She gave me the tools to have the foresight into my actions to assess whether this was the right thing to do or not. And what it boils down to is you got to be able to know when you're screwing up, or when you're not making the right decisions, whether it be professionally, personally, whatever the case may be, because the sooner you recognize that, the sooner you can kind of grow and learn the lessons and move forward. Second of all is also another lesson I learned from my methadone doctor. She encouraged me. It was those little things at the end of my appointments where she ended off with a joke and just tell me, yeah, you got this, don't worry. And she gave me that self-confidence boost. I say it before, I say it again. People are like flowers. You water a flower, it grows. You encourage people, they grow. And the more you can build somebody's confidence up to believe that they are worthy of getting better or capable of getting off or achieving their goals, whatever it may be, the more you can help somebody believe in themselves, the chances are the likelihood's going to go up for their success. Another thing was learning how to fail. I know how to fail because I've thousands of times. I was what my one friend called years ago called me a failure in life, and it was just like, oh yeah. But learning how to fail is it's something that it doesn't bother you so much when you understand that every failure you ever have is nothing but a lesson to move forward to succeed at the very thing you failed at. And over the years, I kind of got conditioned to failing, but I mean, at the same time, it's just my natural disposition to be like, okay, what's the good that's coming out of this? Where's the lesson? And what should I like? Okay, well, how do I solve this problem moving forward? And then and then the more you fail at it, like for every one success I've ever had, I've failed dozens of times. But it was every time I failed that I get the lesson that comes out of it to make sure that I can keep going. But that really falls into, that's how you develop a never quit attitude. It's just understanding how to fail, and that life is a roller coaster for everybody. It doesn't, and once you kind of understand those very baseline principles, I don't know. I think you have the leg up in life. But I just want to say thank you so much. I'm going to play a video here. I know the audio was a touch shoddy when we tried it out earlier, but I'm going to just play this. Hopefully it goes well, but this is a clip from my film.
I would like to see a day when there isn't that judgment that, people getting help for an addiction is no different from getting help for any other medical issue or health concern. It's through by sharing personal experience that puts a face to it and allows people to come out of the shadows and talk about addictions. And I think that's really important.
When I got caught, I decided from that moment on there weren't going to be any more secrets. And so I talk about my recovery. There's no one that doesn't know that I'm in recovery. And that has kept my recovery strong.
If you ignore it, it's going to get worse. Quick.
But I guess my thing is, people think it can happen to them, and it can happen to anybody.
That's what we need, a public outrage. And we need a collective public outrage in order for this stuff to change, because money talks, and these companies have a lot of money.
It's only through banding together that victims of huge corporations, and for that matter governments as well, stand a chance.
The more knowledge you have, the more you can take the greater scale of information, take a good analysis of it, and then come to a logical answer.
It's almost like having your best friend back. That's the kind of feeling I would describe it. I'm extremely proud of him. Most people can't turn their life around, but he managed to do it. The stuff that he was doing destroys lives. It really does.
And when you went through hard times, it makes you appreciate the good times more and not really take much for granted. I don't take a day for granted in terms of where I'm at now in my life and what I got through to get to this point. I just want to say thank you, everybody, for taking the time to listen. Thank you, Rob, Carly, everybody. It was an honor and a privilege to be here today. And yeah, thank you again.
Awesome, Chris. Thanks so much. We did have a couple of questions come in. Do you have a couple of minutes for questions? Would that be okay?
Yep.
Great. The first question that came in was about, you mentioned that you were with a methadone doc for a long time and that you got a new doc and that made a big difference to you. Are you able to articulate what the difference was? What was it about that practitioner for everyone else listening to learn how to do it that made a difference for you?
Well, like I said, it's the contrast between the two. My first doctor didn't seem to kind of like, he just projected that he didn't care. that he wasn't like, he was just kind of getting through his day and looking forward to getting off. The second, my second methadone doctor, her name's Marnie Brooks. She amazing woman. She took the time to figure me out and to figure out like what the problem was, and the fact that she genuinely cared, and that's what built that trust between her and I, was that I knew she had my best interest in mind genuinely. And once I ascertained that she genuinely cared, that's when I started being honest and opening up, and that's when we started actually working together to navigate the process. But that said, I mean, again, like, it was those little things, those like saying or just saying something at the end of the appointment, like, "Oh, you got this," or like, "Yeah, don't worry, just make it through the week. I'll see you next week." And it's just those little things that built up my self-confidence that allowed me to believe in myself that I was able to do it. And again, that building that trust is the baseline to success with in terms of harm reduction in my experience.
I mean, that's so powerful to hear that. And I mean, certainly many of us are advocating that we need programs for opioid addiction that really focuses on spending time with patients, getting to know them, building a relationship. I was speaking to a reporter recently, and I told him that, you can have people pee in a cup 2-3 times a week or whatever. There's no evidence for it, and it doesn't replace the relationship. And it sounds like that's what you had, was a relationship with someone. Someone took the time, didn't rush you in and out with a prescription, but actually spent some time to get to know you. A big shout out to that physician. Hopefully they get a chance to see this, and I'm sure you've chatted with them many a times. I saw a picture recently of the two of you, and it's great.
Yeah, we still talk, and we're friends now. We actually worked together on a project a little while ago, ironically enough, which was kind of surreal, but it was really good. But she's awesome, and my hat's off to her.
Excellent. One last question is what do you have to say to people who are told that they'll have to be on this for life? Many of us argue that that's quite demeaning and demoralizing to hear you'll never get off. What's your message to those people listening?
I remember halfway through my time on methadone where I thought that was going to be the rest of my life, and how depressed I was thinking about that. And there was probably a good year and a half there after that initial thought where I thought that was it, and this is it. And like, I didn't even foresee a day where I was capable of getting off. But again, that was around the time where I switched doctors as well, and because I remember one time I tried to actually do the tapering with my first doctor, and he just wasn't having it. He just wasn't letting me do it, and I was just like, all right. So, but my message to anybody out there is that it's possible. You can't rush the process. You have to. Yeah, again, to your point on your talk, Rob, is that you have to go through that therapy process as well, which is something I didn't really touch on. I actually, with my therapy was my physical exercise when I was getting off. My training, I was doing 2-a-days training up for riding across Canada. Now I do Muay Thai, boxing, jiu-jitsu. That physical activity really, one, helps build your self-confidence, but two, it also gives you into a good mind frame to be able to tackle the problems. But the thing is that, like I said, everybody's tools are different. And the thing is, you can't give up. It's possible, but progress is a process like anything else. And you just keep going. No matter how deep or dark a hole in, things will get better. Just be patient with it. Have time. Trust your physician. Trust the people who are trying to help you. And again, like when you have that mutual trust, once you ascertain that your doctor really genuinely cares about you, then that's kind of your golden ticket to get through that door and start actually working towards it. And just keep going. Things are going to get dark, but things get better. I promise you.
Thanks, Chris. And thank you again so much for being here. You took time out of your busy day. We have a limited budget. You still were willing to do anything you could to help out. And it just shows the amount of passion and compassion you have in this area. The CCSA made the right decision to have you there. It's so excellent that you're involved at a national level. And it's an honor and a privilege to have you here with us. So a big thank you from everyone here to you. And hopefully everybody heard your message, because I hear it loud and clear. Person-centered care. Listen, build a relationship. Nothing means more than the relationship, and your experience helps really exemplify that. So thank you so much, Chris, and good luck at your next appointment, wherever it may be.
Great, thank you guys. And if anybody out there listening wants to get in touch or has a question or anything, my email is chrispcull@gmail.com or inspiredbyexample.ca. But thank you guys again for having me. I really, really appreciate it. Great to see you guys again via screen. And,
we'll get a chance again soon, Chris. Thanks a lot, mate.
Thank you, guys. Take care.
Thanks. So from this point, we're going to move into what person-centered care looks like and clinically what we can do in these kind of situations. As mentioned, Dr. Yu is an addiction specialist here in Calgary who works both in addiction and pain, and a great colleague for me to have around, and very excited to have him present some cases and some of the experiences that he has as a physician providing person-centered care in opioid addiction.
Thanks, Rob. And once again, thanks, Chris, for sharing your inspiring story and your journey in recovery. So I'm going to use this time today to talk about tapering opioid agonist therapy. I don't have any disclosures. So when we think about treatment for opioid use disorder, oftentimes, your mind gravitates towards buprenorphine, naloxone, methadone, and slow-release oral morphine. And while medications are absolutely necessary, especially in the initial stabilization phase, especially when someone is in a crisis and with an increased risk, very real risk of overdose and death, opioid agonist therapy is absolutely necessary. But it's not necessarily all of recovery. And when we think that we can just put a medication, give a patient a medication, and then they're cured from their opioid use disorder, that's doing them a disservice, I would say. Now, Rob had actually previously mentioned the Cochrane study looking at the evidence showing the addition of psychosocial interventions, specifically the flaws associated with that Cochrane study. So I'm not going to go into detail with that, but there are actually a number of other studies that are coming out, some weaker still, but emerging in terms of the many benefits of addition of psychosocial interventions. And I just want to say, as has been reiterated many, many times, that we need to meet the patient where they're at in terms of the spectrum of recovery, where be it harm reduction, treatment, or recovery-oriented services. And you know what, over time, everybody's recovery journey is different. And we need to have the available resources for them to support them in that journey in terms of recovery. And that actually becomes especially important when we discuss opioid tapering. So as of date, in terms of the data associated with how long to keep someone on maintenance therapy for, there's still a lot of debate and different schools of thought. The data is not existent, I would say, at this time. The different schools of thought, there is, as you heard, the diabetes analogy where people have to be on opioid agonist therapy for life. It's akin to insulin. And that's not necessarily the case. At a recent ASAM conference that I attended, the duration of time that was quoted was a minimum 1 to 2 years of sobriety before attempting to taper, with some of the available evidence showing a less than 6 month duration resulting in worse outcomes. One of the analogies that I hear more and more is this cast analogy, where opioid agonist therapy is kind of like a cast for someone who has a fracture for their limb, and it supports someone in that recovery journey while they engage in other aspects in terms of their recovery and in terms of the healing. And once that limb has recovered, once that bone, that fracture is healed, and when the person can support themselves, when that limb can support itself, then the cast may not necessarily be there or necessary. And so I kind of like that analogy more, because it, first of all, implies that there is a recovery that takes place beyond just opioid agonist therapy, and the fact that recovery is not just a pill or a drink. So when we talk about where some of this the thought that opioid agonist therapy has to be a lifelong treatment comes from, let's look at some of the studies that talk about this. So this is actually a review looking at discontinuation of buprenorphine maintenance therapy by Bensley et al. 2015. And I don't know, it might be a bit small there, but it has a number of studies looking at patients who are tapering in terms of their buprenorphine. For the first study, we'll look more into detail shortly, but the first study, if you look here, the Sigmund et al. 2013 study, had a sample size of 50% that had prior heroin use. And they had a maintenance period of 2 weeks with a mean dose of 11.5 milligrams. And you can see here that the abstinent maintenance, so while they were actually on the medication, it was 82%. And then after the taper, regardless of the duration, so after the 1 week taper, it had actually dropped down to 21%, 17% with the 2 week taper, and then with the 4 week taper, it was actually down to 50%. And so in all three cases, after tapering, there was a decrease in the abstinence rate. When you look at the next study, Weiss et al. 2011, in their phase 2, they had patients stabilize on buprenorphine for a period of 12 weeks with a mean dose of 20.8 milligrams. And what they actually found was also, regardless of the taper duration, actually the 4 week, if you look here, the 4 week taper duration, you could see that there was a drop in terms of the post-taper abstinence. And then the Ling et al. Study had 83% with prior heroin use with maintenance period of 4 weeks and mean dose of 20.3 milligrams. And you could see that, even before taper, there was a maintenance abstinence rate of 37%, but that actually also dropped as well. And finally, the study, Woody et al. 2008, looked at youth specifically. And there was a similar decrease in terms of the abstinence rate after taper. This is just a graph for the first study, Sigmund et al., just to give an illustration of that. And so you can see here, it was a double-blind 12-week randomized clinical trial in outpatient setting. They actually had a CRA, community reinforcement approach, in terms of behavioral therapy, which was not necessarily kept track of. They didn't isolate the effects of behavioral therapy. There were no consequences for missed sessions, so it's unclear in terms of how much engagement in terms of that the patients had. But you can see here that compared to the cohort or the group that stabilized, the groups that tapered off 1, 2, and 4 weeks actually had a lower percentage of opioid negative specimens. Then if you look at the Weiss study 2011, there were actually 2 phases. The first phase, he had patients who stabilized on buprenorphine over a 2-week period, and they ended up with a 6.6% rate of successful outcomes. And with the phase 2, where they had a longer period of stabilization of 12 weeks, that percentage increased to almost 50%. And it's interesting that even with a 10-week difference, there was an increase in terms of the percentage of successful outcomes. If we look at then the Ling et al. Study, we can see a very similar trend here, where it was a randomized parallel group open label study where all procedures were identical for all participants until the taper period. And so patients were stabilized on buprenorphine naloxone over a 4-week stabilization period. After that, they were randomized to either a 7-day or a 28-day taper regimen. There was some non-specific psychosocial treatment that was available, but no attempts to standardize, or there was nobody kept track in terms of how much the patients actually participated in these. And you can see here that with each of the tapers that either the 7-day or the 28-day, there's actually a drop in terms of the percentage of abstinence rate. And finally, with the Woody et al. Study, there's even at the 12-month period, it was a study for youth between the ages of 14 to 21. Patients in the 6 community programs were randomized either to the 12-week buprenorphine naloxone group, or they had a 2-week detox group. And you can see there is a clear difference in terms of the percentage of opioid positive urines between the two groups, for example, the 12-month period here. And that also echoes a lot of the recommendations that just withdrawal or detox from an opioid is not treatment. And in fact, it increases the risk of relapse and also therefore death because of the risk of overdose. Now, what about methadone? So there was a population-based retrospective cohort study in BC that NOSEC 2012. And so they actually looked at between 1996 to 2006, they had 14,602 methadone episodes where a taper was initiated. The primary outcome was sustained successful taper. So that was defined as a daily dose of 5 milligrams per day in the final week of treatment episode and no treatment reentry, opioid-related hospitalization, or mortality within 18 months following episode completion. And they actually found an overall rate of success of 4.4%, or 646 episodes, which is pretty low. So the question then is, how long do we actually continue someone on maintenance therapy? And so I would argue that if there is continued benefit, they can continue. However, it is not a benign treatment, and it's a disservice if we just say that you have to be on this for life. The better question, actually, because many patients actually will come to us and want to voluntarily taper, whether with us or without us. And so the more important question that I often pose to patients near the beginning, right after stabilization, is what else, aside from taking a pill or taking a drink, are you going to do for your recovery? And that leads us to what is, and we had already talked about this a bit, but I just want to reiterate, what is recovery actually? And so if you look at the ASAM definition that was adapted in 2016, recovery, and I'll read this and I quote, is a process of sustained action that addresses the biological, psychological, social, and spiritual disturbances inherent in addiction. Recovery aims to improve the quality of life by seeking balance and healing in all aspects of health and wellness, while addressing an individual's consistent pursuit of abstinence, impairment in behavioral control, dealing with cravings, recognizing problems in one's behavior and interpersonal relationships, and dealing more effectively with emotional responses. And while it is true that, as I said, at different stages of patients will require different support depending on what their goals are with their recovery. In some patients, it is just survival, and you meet them where they're at. For many others, it is actually, dealing with the trauma that may have contributed to their use in the first place, addressing their chronic pain. It could also be dealing with long-standing depression, anxiety, or other mental health issues. It could also be dealing with social issues, lack of housing, lack of financial support. And it could be, clarification of values. What provides them fulfillment in terms of life. As we had heard from Chris, he found fulfillment and passion in a number of activities, intense exercise, things like that, and it allowed him to progress in terms of his recovery journey. And so, yes, we have to meet the patient where they're at, and oftentimes it becomes more than just opioid agonist therapy. And so that's where the concept of recovery capital comes in, and this is from the CCSA document 2017, moving toward a recovery-oriented system of care. And I quote, "It's the combination of personal, interpersonal, and community resources that can be drawn upon to begin and sustain addiction recovery," White and Cloud 2008. And so, as we had talked about, recovery journey is an individualized journey, and everybody's recovery journey looks different. And therefore, an individualized assessment that includes screening, that includes, a comprehensive approach in terms of the biopsychosocial, spiritual aspects of care is required. And as well, obviously, individualized treatment planning is also required. And the range of services from harm reduction options, addiction treatment, recovery-oriented services must be available to meet the patient's need when it comes to recovery. And so when I see a patient, typically not only do I stabilize the patient on opioid agonist therapy, we talk about different aspects of life that can be affected by substance use. And this includes things like employment status, housing status, history of trauma, family history of addiction, substance using peers, which is super important when you're developing a relapse prevention plan, and how to rebuild a social network that includes people maybe who are also in recovery, or people who don't use in the first place, dealing with any concurrent psychiatric medical illnesses, any chronic pain that they actually need to have addressed that may have led them to use opioids in the first place, legal issues, financial concerns. And a word about the social networks. Oftentimes, in social support groups are great in terms of 12-step meetings, smart recovery, refuge, and because they allow that person to rebuild their social network through meeting other people who are also like-minded in terms of recovery. And obviously, for many of these, including mental health, trauma, proper screening needs to take place, and proper treatment needs to be provided, whether it be trauma, exposure-based trauma therapy for PTSD, proper medications, different types of psychotherapy, that should be made available for the patient. And so, as I said, many people's recovery journeys are different and require a wide range of resources and programs. And commonly, this will include residential treatment programs, recovery residences, mutual support groups, therapeutic communities, but it's very individualized. So, what are some common barriers in terms of patients engaging in recovery? These are some common ones from the CCSA document that they did a survey, a nationwide survey in terms of recovery, and 55% basically said they did not believing they had a problem, not believing their problem was serious enough, or worrying what other people would think, stigma, not knowing where to seek help. These were the most common barriers for patients actually starting in their recovery journey. Now, this is all super important because we need to address all these things even prior to tapering. And if we don't actually do this, and if all they actually did for their recovery is take an opioid agonist therapy, then it may not actually be sufficient. And so definitely when it comes to voluntary tapering, I would ensure that they actually have adequate recovery capital, that they've actually done more than just take an opioid agonist therapy, that when we actually start tapering, we don't start when there are some acute stressors going on in life, or things that might increase the risk of a relapse. And obviously the rate is individualized and it's very patient-driven, but generally the success will increase if the rate is slow and the rate is adjusted depending on what the patient actually can take. I just had a patient maybe yesterday who we started a taper for, and we actually started maybe just 2 milligrams every 2 weeks. And that's just an example of how you can start. I mean, the rate is very individualized. As well as for methadone, you heard from Chris how he had a very unique kind of a situation in terms of his taper. And it's important to then work with the patient in terms of, okay, so what works, what doesn't work. I just want to conclude just looking at here, this is a buprenorphine receptor occupancy graph that I stole from an ASAM presentation at Alsite at the end. But if you look here, you can see that even up to 12 milligrams, there is actually not too steep of a drop in terms of receptor occupancy, which leads some to recommend basically that the initial taper, let's say from 32 milligrams or 24 milligrams to a lower dose, even for longer term maintenance, may not be that much of a struggle. But as we actually continue to go down, it may actually become, it is a steeper drop, and therefore the patient may actually have more withdrawal symptoms. So as I said, it's very individualized. And, some patients, even with the drops from 32 to 30, they actually have, some difficulty there. And it's important to just work with them and to go slow and to do it at a patient-driven rate. So that's the end of my presentation, and these are the citations.
Thank you so much, Alvis. We've had quite a few questions coming in. So, since you just finished the presentation, the question that came in was asking about your experience in this. And, what is it that you actually say to patients when you first meet them? And how do you talk to them about the possibility of tapering? There's also as to, your clinical experience in deciding who should taper and how do you make that decision?
So those are great questions. With regards to what I do when I first see a patient. So when I first see a patient, they walk in the door. Oftentimes, they're using opioids, and they might have a lot of psychosocial issues that aren't addressed yet. And so the first order really is their survival and stabilizing them in terms of, for example, use of opioid agonist therapy, harm reduction measures to maximize the chance of survival and to decrease the risk of an overdose. And so the first thing I would do is obviously assess for use of buprenorphine naloxone, methadone, SROM to stabilize the patient. And then what happens is once we are in the process of stabilization, we start to go deeper into what are their medical issues, comorbid medical issues. You screen for hepatitis, HIV. You screen for comorbid mental health concerns and trauma. And oftentimes that also requires the use of, screening tools. For example, with PTSD, I commonly use the PCL5. And then obviously that doesn't take the place of a good interview where you actually do a proper psychiatric interview and explore some of their mental health history, right? And then what happens is it depends on the type of mental health concern. So for example, with depression and anxiety, so we want to be able to tease out what is substance induced and what is a primary mental health concern. Both will do well with psychotherapy. So I would offer that even initially at the get-go, or as soon as the patient is stabilized and they're willing and able to engage in that piece of their recovery. And then with time, we can then tease out, okay, so what kind of primary concerns in terms of their mental health, medical health do we need to actually address? and then you just treat those, and you offer proper resources if they need to have that treatment. For example, exposure-based trauma therapy, as I mentioned, for PTSD, or referring them for proper treatment for their hepatitis or HIV. And then the second question, what was the second question?
When do you decide to taper? How do you have that conversation with your patient?
So there isn't actually a one-size-fits-all when it comes to that. Oftentimes when I follow up with a patient, we continually, with every check-in, we talk about, okay, so, what's going on in life? What kind of psychosocial issues are still not dealt with, or what are dealt with? Have there been, we also talk about values. We talk about, okay, so what kind of things are you passionate about? What kind of things provide your life with fulfillment that you can actually, replace that addiction with? And we start to explore those things. And eventually, we actually come to the point where we talk about tapering, and there isn't a set time frame. Oftentimes, if they come in after a couple weeks or a month and they want to come off, then I'd be, okay, well, let's explore, okay, have we done everything that we need to do? That aside from taking a pill or taking a drink for that recovery to take place. But there are many times actually the patient will come to me and they will ask, okay, so when can I actually come off? And it actually comes to the point where at the very first couple sessions, I will actually say to the patient, okay, well, especially for people who are on buprenorphine naloxone, I will say to them, I'm like, okay, well, you know what? In a couple months or half a year, whatever, you probably will come to me and be like, okay, doc, I want to come off this thing. And many patients will actually be on lower doses than you prescribe them. And if you don't even ask them how much they're actually taking, how often they're taking it, you won't find that out. And they'll have a stash of buprenorphine naloxone in their house that and then what happens is you find that they're missing appointments to the pharmacy, and they say, oh, you know what, I'm still taking this lower dose because I have a huge amount of medication at home. And we want to avoid that because we want to work with the patient in terms of the dose that they need, and concurrently we don't want to get to that point without addressing all the other aspects of recovery that they may need as well. And so actually in the first couple of sessions I'll already mention all this, and then we'll start to work towards dealing with all the comorbids associated with substance use. So unfortunately, I can't give you an answer in terms of the time. I mean, there is that ASAM recommendation of 1 to 2 years of sobriety. I mean, that it's also very individualized. I wouldn't do it if it's too short. Like if it's 2 weeks, 1 month, it might be a bit short. But obviously, this is very patient driven.
Great. You also mentioned in there. You know what, Cristina? With you do the same thing in iOAT, and you've worked in opioid replacement as well. What do you think?
I really try to assess the why behind the request for a taper, because the reasons are very enlightening. Because sometimes it's as simple as I can't get to the pharmacy every day, or it's I got a job and I can't come to iOAT 3 times a day, but I can come in the morning, I can come in the afternoon. So if you look at the reasons for the ask, then it does help you plan with the client what you're going to do. So sometimes it's drug coverage. I can't afford my medication anymore. And so again, it's all those psychosocial factors, but sometimes it's as simple as I can't afford to buy the pills, or I got cut off my coverage that I had before. So assessing those basic things all the way along, to me, can really guide a taper, because then you'll know why. Sometimes it's changing the carries or the take-home dosing plans so that they have more flexibility in their life if they medically need to stay on that dose, but then logistically we can adjust their dosing approach so that they can carry on with other aspects. But I do agree with everything that Dr. Yu said in terms of pacing, client-driven, and reevaluating in every visit, and really looking at major life areas and what's important to the client before proceeding. Also want to know what other people in their lives might be gunning for a taper, because then that brings in maybe a family systems aspect or a couples therapy component of their treatment that might be worth looking at. If there is pressure from a loved one to get off this stuff, or there's the stigma around it as, well, you're just addicted to another drug, if that is underlying their desire for a taper, then that needs to be addressed separate from just prescribing differently.
Yeah, I totally agree with that. I mean, I don't know how many family meetings I've done where we've discussed exactly that of, this isn't just being addicted to another drug. This is a tool in recovery and a tool to help, Johnny or Beth get through this process. I often have collected patients from other clinics or other physicians where they've been told that they can never get off. And when, our first visit, we talk about the fact that this isn't a permanent thing for everyone. Some people can get off over a period of time. It's often response with amazement and shock of like, oh, really? I could get off? Absolutely. There was a question here about, Alvis, you presented information stating that if you stop the medication, that relapse rates are much higher. And I think everyone at this panel agrees we don't detox after a week or 2 weeks or a month. The CRISM guidelines, the BCCSU guidelines less so, but the CRISM guidelines and the ASAM guidelines very clearly state if you're going to taper, you just have to do it over a long period of time. And we should be assessing for stabilization elsewhere, psychosocial, have we addressed the trauma? Have we addressed the housing? Are they still hanging out with the same people who are still using? Because that's going to be a huge trigger to them. But at the end of the day, the evidence for long-term tapering, we're talking about 80% continued and 50% if they were tapered at a couple of weeks. Long-term retention rates in most methadone clinics are 50% or less. So it gets really tricky trying to interpret and understand the evidence. But again, I don't think anybody at this table would ever suggest that we taper someone after a few weeks or even a couple of months. Often it's a lot more education. We're lucky enough to work in programs where we have group DBT programs, group CBT programs, mindfulness programs, individual psychology appointments. The evidence suggests that if we give personalized approach, we get better outcomes in opioid use disorder, and that's what we follow, and that's what we're seeing. And we're lucky that we get to work with colleagues. If, to have Cristina around and to go bug her about something and vice versa. And, to know we can get a pain assessment, an addiction assessment, a psychiatric assessment, an internal medicine assessment, primary care screening. I mean, people are getting vaccines for the first time in years. It's amazing. And this is what wraparound services look like. And the fact that we work in opioid therapy and all agree that the goal has got to be long-term recovery. And some people may not get there, and everybody understands that. But that doesn't mean that we shouldn't be trying. Could you imagine where we just decide, nope, everybody stays on it. This is your insulin. You're going to need it. Your pancreas doesn't work, and you have a brain that's never going to let you be abstinent. I think that's crazy talk. It's financially motivating if you're making money off of it, but outside of that, there is zero benefit in doing things like that. The goal has to be working individually with each person. And some people, they just don't have the recovery capital, or they don't have the psychosocial stability, or we can call it a variety of different names. They're just not quite ready. And ideally, what we'd love to do is send them to a 3 or 6 month residential facility where they get full supports of from psychological to social to housing to a driver's license to getting their taxes done so that they can actually get medication coverage to, everything that needs to be stabilized in one's life. And right now, we have some great programs out there, but there's wait lists and costs, and it's difficult to really look at recovery in these individuals that on an outpatient basis, we're just not going to get them there. And that, in speaking of that, we also know we were talking about the fact that next year, this is our last session, and we're going to take the summer off, and then we'll be starting again in September. And next year, we're going to be incorporating a lot of other substance use, talking about methamphetamine, for example. And a question came in, Cristina, are we treating methamphetamine use disorder and agitation and all of this? Is this common? Are we seeing an iOAT, and what are we doing about it?
It's very common at iOAT. The majority of our clients can currently use methamphetamine along with their opioids. Certainly there's toxicities that result from using both together, or just the meth alone is incredibly potent and accessible in Calgary. So it's something we've had to address. Even though we're an opioid use disorder treatment program, we cannot ignore meth and the impacts it's having on our clients and then society in general. It's huge. So I'm glad there's going to be more time spent on that next year. We're working on guidelines for treating a meth toxicity in our treatment environment, but also we'll be able to expand that beyond our setting, and looking at how we can meet clients around their meth use and help them reduce their use and reduce the harms of their use as well. So there are some studies done elsewhere and in the works in Vancouver regarding the use of prescription amphetamines. Outcomes are still, we're still waiting what the results of that research looks like, but we're trying again to reduce the harms, lower some of the risks involved, and keep that topic of meth use on the table with our clients so that we're acknowledging it, we're continuing their treatment for opioid use disorder despite the meth use as well. I think historically, had there been concurrent stimulant use in traditional methadone clinics, that would have been reason for discharge and tapers, forced tapers. Now we still carry on with treating their opioid use disorder even with the meth use, because we know that is still safer than cutting people off. But it's absolutely on our radar because it's ever present.
Yeah, absolutely.
So it seems like there was a question with regards to the duration to taper, and if you look at the BC guidelines, there's an expert guideline portion of it, and they say that, so as we had said, a longer taper that is obviously individualized is much more conducive towards success. In fact, they quote more than 12 months. The studies that I actually had for my PowerPoint, the longest duration that they were on opioid agonist therapy, buprenorphine included, was 12 weeks. And so obviously we're not saying, go and, force tapers off everybody on opioid agonist therapy. No, that's crazy. What we're saying is that we need to actually, as long as there is benefit in terms of the opioid agonist therapy, which allows the patient then to potentially explore other avenues in terms of their recovery, then that's beneficial and it should be continued. And this has to be patient-driven. And oftentimes, the duration of it, you can make recommendations, but the patient will also have their ideas in terms of how long they want to be on it. And as Cristina said, and I echo this, it's important to explore why. And if it's because of this daily dispensing with buprenorphine, then we got to ask whether that's a great idea.
Yeah, there's no evidence for daily dispensing buprenorphine. None, zero, zip. We're the only country in the world that has patients take buprenorphine in front of a pharmacist. Witness dosing of buprenorphine doesn't exist in the United States, doesn't exist in most other areas around the world. It was the way it was introduced and thought to have been as dangerous as methadone, when in reality it's safer than a Percocet. And when we're treating individuals, we actually just published the Calgary SROM approach of transitioning people from methadone to buprenorphine to have more freedom and to have more functionality. Many people struggle, and we've collected these patients many a times. They're not allowed to go to work. They're not allowed to go up north because they can't get their methadone dispensed at another pharmacy. Certainly not a problem that we run into in our clinics, as we either rotate them over to buprenorphine, and there's several different methods. And we actually have another paper that's in press right now of 6 different ways to rotate people from methadone to buprenorphine to allow that functional freedom that individuals are asking for. And again, I fully agree with what Alvis said and what Cristina said. This is about person-centered care. Listen to the person in front of you. Work with that person in front of you. If that person is talking about trying to get off, let's assess what we're talking about. There is no hard and fast rule here. But most importantly, we don't detox. We don't rapid detox. And all of those studies, as mentioned, were less than 3 months of treatment at low doses of methadone. If we're looking at where many of our patients end up in that 80 to 100 milligrams, it's going to take a long period of time to taper off of that. And we nicely heard from Chris, it took him 5 times before he got it. And you know, we have to support people. They may fail at times, they may struggle at times, they may need to go up at times, but we keep working with them, and we help them achieve their goals. And part of the job of being an addiction medicine practitioner, whether you're an NP or a family physician or a psychiatrist or an emergency doc or a public health doc, it doesn't really make a difference. Our job is to be providing more skills, to be listening to the people in front of us, to be figuring out what's leading to a relapse or what's leading to increased cravings. Not just this idea, oh, doc, I have some cravings again. Oh, well, let's increase your dose. That's not the answer. The answer is what's going on for you, what's leading to more distress in your life. You know, some simple things of halt, hungry, angry, lonely, tired. This is something that you learn, hopefully, your first week of addiction medicine training. It's listening and working, not just prescribing. And I'll say it again, we're never going to prescribe ourselves out of this crisis. So can we receive a link about that article? Well, sure, when it's published, I'd be happy to give you a link. We presented at WCAF not long ago, and we've sent it in for publication. We're just waiting for the review process. So obviously, once it's out, we'll have Addiction Day tweet it, and we'll get it out there for everyone to take a look at it. The SROM approach was published this June episode of the Canadian Journal of Addiction. So you can take a look at the journal there, and you'll see how to rotate someone using Cadian from high-dose methadone to buprenorphine without having to taper anyone. Dr. Yu is one of the authors as well. And we've got quite a few different studies that we're working on in these areas. But regardless, coming back to everything, it's about person-centered care. It's about listening to the people in front of you. It's about encouraging recovery and figuring out what it is for them. For some people, maybe it's I'm going to bike across the country. I'm guessing that's not the majority of our patients, that's what they're going to be looking for. But maybe it's I want to go back to work. Maybe it's I want to find my own place. Maybe it's I want to get treatment and help. There's a lot of belief out there that people who struggle with opioid addiction don't want any sort of therapeutic interventions. I haven't had that problem. I mean, we have a lineup and a wait list for people wanting to get into our groups. They're knocking on the door asking for help. I think these are myths that are put out by low service, high volume clinics, because that's simply not true when you have a relationship and you identify high ACEs and you identify any sort of mental illness that may be intermixed from PTSD to depression to anxiety, and identifying them and then treating them and then letting them know the best treatment is actually to get into our therapeutic groups. We have not had a problem getting them in. We don't have a problem at iOAT with people wanting help. People want help. The problem that we have is we have very little help. So we've spent a lot of time and energy on harm reduction, and this is important because we don't want people dying. But we need wraparound services. We need access points to treatment. And we need ability for people who want to go into recovery to get into recovery. And we need the voices of people who are in recovery helping them through that process. There's been a lot of voices out there really working hard for safe supply, which is important. We have very dangerous stuff out on the street. We have great voices out there for harm reduction, which is extremely important, and safe places to use so people don't die. What we really need now are voices for help, for recovery, for people who say enough is enough. I actually want to stop doing this. We shouldn't be like, okay, well, that's nice. We'll put you on a wait list, or do you have money, or do your family have some money, or is there, we shouldn't have to say any of that stuff. It should just be, yep, absolutely. Let's get you in the next couple of days, or even today, or straight now. If somebody shows up at hospital and says, I need help, I really want to be able to do something, we shouldn't be sending them home saying this is an outpatient problem. We shouldn't be sending people home saying, sorry, we don't have addiction beds in our hospitals. And unfortunately, that's the reality that we live in. We don't have addiction beds in our hospitals. In Calgary, not one, zero. We're the fourth largest city in the country, and we don't have one addiction inpatient bed in Calgary. Think about that for a second. Imagine if we said that about cancer. Imagine if we said that about liver disease. If we said that about knee replacements. I mean, when we had the knee replacement thing, it was all over the news, and how dare we be in this position? And yet here we are in this position. So I continue to ask you all to be the voices that the people need. We're talking about the most vulnerable population, period, in Alberta, in Canada, in North America, in the world, who are struggling every day to stay alive. And they're at the highest risk of being taken advantage of. And we need to be those voices. We need a public system. We need everyone being taken care of, regardless of who you are, where you come from, and how much money you have. We need to eliminate profits that are happening in this, and working with industry if we have to, whether we're using publicly funded money to purchase beds at residential programs. Alberta Health has done an amazing job right now in coming out with actual legislation so that our residential programs in Alberta have to follow some rules, and that have to be registered, and they have to be licensed. And now that we get to that point, we now need to access them regardless of who you are or where you're from or how much money you have. We need to treat it like cancer. We need to treat it like heart disease. And until we do that, we can talk about breaking the stigma all we want. We can have commercials. We can have everyone talking about stigma. The minute we bring up stigma, we propose stigma. What we need to do is treat it like we treat everything else, and quit treating it like they're a second population, a lower population, a lesser than population. And when we do that, we will change everything. And with you joining us today, you are helping that process. And thank you for being here. Thank you for your questions. I'd like to end with a few comments that we've received from people. And now I'm getting more questions. Moving from the questions, I don't understand. Should we wait 1 year, 5 years? Or there's studies that tell, we don't know. But as mentioned, the BCCSU says 12 months.
Yeah, but The research out there is still ongoing, and I don't think
Yes.
there is actually something that for that long of a duration yet. But I mean, we'll have to do that research really, and that's really the future direction of addictions as well.
Absolutely. We've seen so much time and energy going into kind of programs such as, harm reduction, claiming that treatment isn't working. We haven't really researched treatment, so how do we know it's not working? Anybody who works in a treatment facility would completely argue it doesn't work. They have many patients that have recovered. We just need them to have a voice. I'm going to read out over the last year some of the comments that we've received from you. And we've received a lot, and I can't read them all, but these are just a few that kind of touched us when we were going through it. I just wanted to reach out quickly and say thank you for the work you guys do. I have a very deep and long-standing familiarity with addiction, and I've been thinking a lot about what you guys have said about physicians being partly guilty for people's addictions. In a weird kind of way, by saying that, you really gave me some closure. I appreciate it, and I appreciate what you guys are doing, and I appreciate that you have the courage to stand up to clinicians and their prescribing powers. Thank you. These virtual sessions have changed how I deal with my patients. The knowledge and research is second to none. Thank you for this great educational opportunity. Thanks for the great presentation, everyone. How each of you see what we incorporate into the lessons learned from lived experience into clinical management of patients and meeting them where they're at is amazing. I could go on and on with all of them. Thank you for watching. Thank you for wanting to make a difference. Thank you for wanting to make a change. Until it's considered just another disorder that we're treating, we're going to be in this position, and until you look at it like, hey, I've got this and I can handle this and I'm not scared of it and I'm not worried about it and I'm not in a position where I don't know what to do, it's going to be so much easier. When you're confident, the patient feels more confident, they're going to feel better about it. And our next big steps have to be moving into treatment. I've been saying this for the entire year. You're probably getting sick of hearing me say it. But we need treatment. We need facilities that focus on it. We need facilities that focus on the background traumas and adverse childhood experiences. We need to provide people with skills so that they can move forward into recovery. And we need to have people feeling good about themselves again. And that's part of our job. And you are now part of the solution just for being here. So thank you. We're very excited to see you again next year starting in September, and we'll be sending out information when our first one comes out. Do you remember the date?
I think it is. Yeah.
It's preliminary anyways, but
Yeah, we are going to be on September 20th.
September 20th. Think September 20. Put it into your phone, put it into your calendar, take your morning off, and we can't wait to see you. If you miss it, go to ahs.ca/CD series. You'll be able to take a look at it at that time. A big thank you to Jeff and his crew at Livestream that have made this really an amazing project for us to be working with. Thank you to Alberta Health Services Addiction and Mental Health, who continue to support us and often tell me less and less that I have to keep it down. So that's very kind of you to do that. But to Jill Mitchell and Nick Mitchell and Barry Anders, Mike True, the crew there, you guys have been amazing in supporting this process. To Carly for just being amazing and keeping this all together, because I couldn't do that. It's awesome that we have this all put together. And to each of our speakers, Cristina has been here more than once, and thank you, Cristina, and she'll be here more than once next year too. We hope, anyways. And to Alvis for coming, and really all of the speakers that we've had over the year. We've had experts from all over the country and people with lived experience who have joined us as well, and we hope to increase that again next year. I think that we need to hear from you and what you want to hear as well. So send us your comments. We tried to put together a schedule based on what you were looking for. So we'll be talking about methamphetamine. We'll talk about cannabis. We'll talk about alcohol. We'll still be talking about opioids as well. And we'll be looking at all the new and current research that are out there. And we'll be talking about pain medicine. We'll be talking about trauma and mental illness and ways to treat psychiatric comorbidities in this population. We have another amazing year next year, and we sure hope you can join us. Until then, thank you again. You are the solution. Thank you for being here.